see it?
I
Yeah.
can see it's
Okay.
really small, but
Well, there.
there we go. All right, next slide. All right, so as we said, so we're going to be, the overview is that we're going to be going over what a medication is, when it's needed, and how to give it safely to our children. The next part is going to be the actual how to give the medication, and then we're going to go over the as needed emergency medications. Those are going to be our medications for anaphylaxis or our seizure meds or our medications for our diabetic patients. And then the other part of the administration for medications is going to be the Form 1055, which is the documentation part of it. Next slide, please. So as I was mentioning, the overview and what medications are. So medication are anything such as antibiotics, over-the-counter pain relievers, are Tylenol, Motrin, those kind of things, medicines that are needed for emergency use. These are all in the category of what a medication is. A medication in the definitions of what we're going to be calling now are not things such as sunscreen, lip balms, hand lotions, hand sanitizers, the insect repellents, and then the non-prescribed diaper ointments or creams. Those are not considered as medications for this purpose. Medications must include instructions from the prescribing provider, and that should be clearly labeled onto the container or the ointment box or whatever is given to the CDC or CYS, I should say. They can be prescribed for up to 12 months. And I know that as a provider giving the instructions to a parent, I do tell parents that they can mix certain medications with juice or food to make it more palatable. However, that is not the regulation for how you're supposed to give medications while the child is being given the medication at the youth center or at the CDC. So just so you guys know, if you have kids at home, it's fine to do that if your doctor has told you that that medication can be mixed, but for your own child. But while you're taking care of the other children at the youth center or at the CDC, the recommendation is that it should not be mixed with liquids or fluid unless it is written on the container for the medication that the doctor has said that, yes, this can be mixed with fluids or liquids or food. So that's probably the biggest differentiation of how when we are giving medicines to our own children in our homes versus when we're giving medications to the kids at the youth center or CDC. Medications must be stored in a secured area, and they should be inaccessible to all the other children and the youth that are at the center. For the care providers who have the daycares in their homes, you don't have to have a separate refrigerator for the medications. However, it should be that the place where you're storing the medication must have a child-proof lock so that any other child going into the refrigerator to grab whatever doesn't grab a medicine and inappropriately take that. And those are all in the regulations that all the FCC providers are aware of. Medications are not going to be stored beyond the expiration dates. So the only time that this is something that we allow is if you know that there is a national shortage. For example, a couple years ago, we had a national shortage of EpiPens. And so the manufacturers themselves had said, hey, these medications can be extended for this amount of time. And it was very specific to the different lot numbers, etc. So those are very specific guidelines, but in general, medication should not be stored by the youth center or the CDC beyond the expiration date or the stop date. Next slide, please. Whenever you're actually giving the medication, so now this is going to apply to the actual medication being given, it is recommended, highly recommended, that the same CYP personnel is the one that's giving the medication to the child. And that's mainly because then you are the same person who's drawing up the liquid, the same person that's giving it to the kid. It just helps to have that consistency, and it's easier in that sense. The other part is that if a medication says that it needs to be given 3 times a day, then that medication is going to be given by the CYP personnel only once during the typical day. So that's if they're there for 10 hours of care. If the medication on the directions or the SIG, if it says give to the patient 4 times a day, the CYP personnel are going to give the medication 2 times during the typical daycare periods, which is the 10 hours. The only thing that this wouldn't apply is if they're in the FCC home settings where it's more than 12 hours per day, then obviously those FCC providers would need to give the medication more than just the once or twice that we talked about. If a medication says that it needs to be administered 1 or 2 times a day, that medication should not be given by the CYP. That should be given in the home by the parent before the child comes in, because if it's only once or twice a day, the parents can clearly give that medication before or after they are at the CDC or youth center. The other parts is that the parents do need to be aware right away if there is any type of adverse reaction that happens to the child. So if the patient gets any symptoms of difficulty breathing, facial swelling, lip swelling, or they have later symptoms such as diarrhea, skin rash, they start getting a fever, or if the kid is flat out like refusing or continue to spit it out or pushes the medicine away, whatever the situation is, the parents need to be notified immediately of that reaction. It is also recommended that for the very first time that a kiddo is getting a medication, especially antibiotics, that first dose is given at home by the parents so that the parents can observe for any of these side effects or changes or refusal to take the medication, that kind of stuff. It is also recommended that the patient gets that medication, the first dose given at least 20 or 30 minutes before they're coming to the CDC again, so that the parent can watch and see, hey, did my child take the full dose? Is the child having any issues with the medicine? And that's the recommendation for it. And of course, if there's any errors that happen, so if there's an error in the documentation, if there was, hopefully this will never happen, but if the wrong child was given the wrong medication, those are also that, sorry, I just saw some sort of comment come through. Maybe Miss Beverly can just pause if she needs me to answer whatever question came through.
What we're going to do is we're just going to wait till the end
Yeah.
and then read the comments, in the chat, and then answer any questions, Dr. Reyes.
Okay, sounds good. I'll try not to get distracted by the comments. All right, so if there is anything if there's an error in how the medication is given to the patient, or like I said, either the wrong dose or the wrong child got the wrong medication, anything like that, that needs to be reported to the parent right away, as well as a medical director. The medical director needs to be notified. I know that we had a situation earlier, I think it was last year, where one kiddo's breast milk was given to another kiddo, and I got called right away, and I was notified of it. We researched what we needed to research, and I also talked to the parents within 30 minutes of all of this happening. So that is the right protocol. That is what should have happened, and it did happen. So that was wonderful. As far as for the kiddos that are in the school age program, if the medication forms say that the child is trained to take their medication, for example, their asthma inhalers, the forms that we fill out that say that this is their asthma action plan, there's a box in there that says, do you as a provider giving the medication think that this child is able to take the medication on their own? If that box has been checked and the kid knows how to take the medication, then the child can take the medication. However, the CYP personnel still need to observe and make sure that the child is taking the medication the right way, as well as that the child is not just taking the medication willy-nilly and around other kids. So the kid should still be in a separate area and being observed taking the medication. If there's a field trip, then the Form 1055s should accompany the group as they're going. And so that way it can be documented that it would be needed as far as that the medication was given and that this is what happened. So that Form 1055 needs to go with the group along with the medication, obviously. And in those situations, the CYP leader is the one who's going to need to hold on to those medicines while they're on their field trip. Next slide, please. So this is just going over the different forms of how medications are written and what type of medications and the different routes for how medications are taken. So PO or oral by mouth, you can have it in tablets, capsules, or liquids. And all medication should be given with at least 4 to 6 ounces of water or juice, milk, something that makes it easier for the kid to swallow that medicine. Now, liquids come in different forms. They come in syrups, which are clear, elixirs, which are also clear, and thinner liquids. And then there's suspension. Suspension medications are not clear and usually need to be shaken up. And those are usually our antibiotics. And the main reason for that is because they've added several different ingredients, and you need to shake it up to make sure that all the ingredients mix appropriately before you give the medication. And then the next category is topical medications. Now, these can include anything from eye drops to ointments, ear drops, creams that are applied on the skin. You want to make sure that you're always washing your hands before you are getting ready to do the topical medications and also afterwards. And it is recommended that you wear gloves. I think most facilities are now latex free. But please do double check that you are using, especially if a child does have a latex allergy, that you are using a latex-free gloves for that child. In general, I usually don't recommend or write. I usually tell my patients for eye drops or eye ointments, I usually recommend that that is done at home because it is very difficult to do eye drops and eye ointments for little children. Sometimes even their older kids struggle as they're seeing that drop kind of come towards their eye. So I usually recommend that those ointments and drops are done at home. But I'm sure there's other providers that order it for more frequent use, and so you may come a time that you may have to do that. One of the tricks I will say is if you are using eye drops in a child, one trick that can be helpful is to have the child look the other way. So let's say you're trying to put the eye drops into their right eye, have them look towards the left. So whether that's either a toy or some sort of electronic device, have them have their eyes gaze towards the left, and then you're going to put the drops in from the right. The natural reflex when you're trying to put the drops in directly, whenever we see something coming towards our eye, we are going to want to blink and we are going to try to no, that's our natural reflex. So if you're putting the drops directly in, your child is going to struggle more. So just have them look the other way and then come in from the corner, basically. Just a little tip. And the next medication, so then we have inhalers and we have our nebulizers. So we can have those in nasal form. So nasal forms are going to be our nasal saline spray, Flonase, those type of medications. Those are things that are given directly inside the nose or the nostrils. The recommendation for that is, we call it the tip to toes method. And so pretend my finger is the tip of the nasal spray. You're going to aim that towards the outside of the nose, not the middle of the nose, but the outside of the nose. And the child should look down and then spray. And that helps because the tissue that we're trying to help decrease the swelling, whether it's from Flonase or with the nasal saline, is actually on the outside. It's not in the middle of our nose, it's towards the outside part of our nose. And so that's why the recommendation is to aim the nozzle towards the outside of the nose, have them spray, but they should also be looking down, and then they're going to inhale like that and get the medication in. The other things will be our inhalers. So inhalers or asthma medications, I should say, come in a couple different forms. One is the MDI, which is the meter dose inhaler, and then the other form is our nebulizer. So the MDI, the most common form that you guys will probably see is the albuterol. That one it's a small little metal canister, and it gets put into a spacer, which is usually a plastic chamber. Some spacers have a face mask that goes over the patient's nose and mouth area, and others chambers are just a plastic tube. The MDIs, the inhalers, are designed to be used with the spacer. The purpose of that spacer, that plastic tube, is that when that medication is dispensed, that it hits the walls of the spacer and it breaks the particle size even to smaller amounts, smaller sizes. And then that medication is absorbed a lot faster into the airway and into the lungs where we need the medication to be. If there is no spacer available, you can use one, you can make one with a plastic cup or a little tube, or you can put the MDI 2-finger spaces from the patient's mouth. The main reason why we recommend that you don't put the spacer directly inside the, not the spacer, sorry, the MDI, the inhaler, directly into the patient's mouth is because when we give the medication that way, most of the medication hits the back of the throat and does not go into the bottom of the lungs. Now, at the youth center and the CDC, you should always get a spacer. Like, I think that most doctors, I know that I definitely order a spacer and an inhaler, and both should be labeled for that patient with the directions that say for the youth center or the daycare or school, whatever the case is. But they should always, if a kid has asthma and they're bringing an albuterol, their rescue inhaler to you, they should have a spacer. Okay, so make sure that you have that spacer for that child. Nebulizer is another way to give medications such as albuterol to patients. A nebulizer is a liquid that then gets put through a pressurized machine, and there's a lot of extra tubing and a lot of extra stuff that comes with it. And then basically that particle mist or that spray is inhaled by the patient. Nebulizers are usually used only in the really young children, and we are also trying to continue to phase nebulizers out, mainly because the MDI has a much smaller particle size and it gets into the lungs, into the deeper areas, much more efficiently and better than a nebulizer. And also just the time, a nebulizer treatment can take up to 20 minutes or so to give the medication. And a lot of the medication when you're using a nebulizer goes in the environment. So the caregiver, the parent is inhaling some of this albuterol as they're trying to give their kid the nebulizer as well. So most people now are trying to move away from nebulizers and doing the more efficient way of using the inhalers. But just in case you're coming across a patient who does have a nebulizer. And then the emergency medications, we're going to go into those a little bit more in the next couple slides. However, the main medication is going to be the EpiPen. So an EpiPen is a medication that you are giving for anaphylaxis, and I'll go into more detail on that. Those are the main forms of medications. Next slide, please. So I think it goes without saying, whenever you're handling a medication, you should definitely wash your hands. If anything that COVID has taught us is hand hygiene and avoiding touching our face and nose has helped a lot. But the main thing is good hand washing. So the general rule of thumb is warm water and soap, sing the happy birthday song 2 times. And so you get about 20 seconds. If you don't have soap and water, then the alcohol-based hand sanitizers are fine. But in general, just wash your hands. The other thing is to avoid actually touching the medication. So when you're dispensing the liquid or when you're dispensing the pill, try not to actually touch the medicine. Try to pour the liquid appropriately. And then even the capsules, you can try to put the capsule or the tablet into the lid of the container and have the patient grab that. As far as the cutting or crushing of tablets, that's only going to be if it actually says on the label that that's what you need to do. When you're measuring liquid medications, this is similar to when we're baking. You have to put the container on a flat surface. You need to be at eye level with it and then pour the liquid to the amount that it says. So if it says 5 ml, that medicine cup should be on the flat surface, and then you pour the amount until it's at that 5 level mark. Now, the little younger babies and kids should have an oral syringe or a dropper that comes with their medicine. The older kids are probably going to have the little medicine cups that you guys know that you see in the Tylenol and Motrin that you buy. The main thing is keeping it at eye level so you're not giving them a little bit higher dose. Next slide, please. All right, so the 7 rights of the medication is going to be always verifying that it's the right patient, it's the right medication, the right dose, the right route. So we're giving it by mouth versus topical, on the skin, whichever way it says on the directions. that we're giving it at the right time, and that we are documenting the right way. The right to know really is mainly for the older kids, I would say. Like, everybody doesn't need to know why little Johnny is getting whatever he's getting. Um, just as a way to kind of protect our privacy and obviously the patient's privacy, right? So that's the main reason for that right to know. I would say the main things to focus on is to make sure that we're giving the right medication to the right patient at the right time, and it's their appropriate dose that we're giving them. Next slide, please. So now these are our emergency medications. So the emergency medications, albuterol is the rescue inhaler, and that's used for asthma flares. Each child that's attending at the CDC or youth center should have an asthma action plan that has it delineated on when the child would need their albuterol and how many puffs of the albuterol they would need and what to watch out for. EpiPens are epinephrine, and that is used for anaphylaxis. And if a child is having anaphylaxis, I'm probably going to go over this in the next couple slides, but basically, if a child is having symptoms of anaphylaxis, that epinephrine is what's going to save their life. So don't be afraid to use epinephrine if the child is having anaphylaxis. The other medication that's an emergency medication is Diastat, and that's for seizures. Glucagon is for our diabetic patients, and that just basically helps to stabilize their sugars in a much faster way. The action plans are always filled out and should be filled out and current within 12 months. If a patient does not have an action plan, but you find out that they have a diagnosis of asthma, that parent needs to be told to have an action plan filled out by their healthcare provider right away, and that needs to be on file. And in that action plan, there are details about what particular triggers are that for that patient, as well as what signs of distress to look for and when the medications should be given and what medication should be given. Then the next part is going to be the 1055. That one needs to be filled out annually. And this, the reason for this is there are times where, like, we may have somebody who has an asthma symptom, or usually you're going to come into this as far as an EpiPen for anaphylaxis. If a child does not have a known history of a food allergy, but then does develop symptoms of anaphylaxis, they would need epinephrine. And so that's the reason why that 1055 is filled out annually by the parents, because that's giving you as a care provider the authorization to use this emergency medication while you're trying to get a hold of 911, while you're trying to get a hold of the parents, etc. I know that at the schools, most schools, not just DOD, but most schools have emergency EpiPens available, because it doesn't have to be that the person with only with the food allergies could have a reaction. Anybody can have a reaction, and so it's part of the emergency stuff. Here, because our ambulance services on base, I think that 911 could be called faster if you don't have a spare EpiPen basically available. Let's see, the other part is that obviously if you need to use, so now even for our asthmatics or for our diabetic patients, if you have to use their emergency medications, if you needed the glucagon for the diabetic, the parent needs to know that you gave them their emergency medications. If you needed to give them their albuterol as a rescue, even if you were following the directions on the asthma action plan or the diabetic action plan, the parent still needs to know that the medication was given. And obviously you're going to be calling the parent because they need to further monitor the child, because the child may need more, they may need to go to the ER, they may need to go to urgent care, they may need something else. So obviously you're going to be telling the parent that, hey, I just gave Johnny this, please come and pick him up, or whatever the case is. Let me just double check my notes. Okay, next slide, please. All right, so more details for epinephrine and anaphylaxis. So anaphylaxis can happen from any type of allergen exposure. And basically, anaphylaxis is a life-threatening allergic reaction, and it can be from food. The top foods are listed there: nuts, fish, eggs, shellfish. But it can also happen from insect bites. Medications can also lead to anaphylaxis. Latex can, it's pretty rare. Exercise is also pretty rare to get anaphylaxis from that. But people that have cold-induced urticaria or cold-induced, basically they get hives when cold things are touching their skin, they also can have anaphylaxis if they're like swimming in cold water or anything like that. So that is something that can happen. Some of the symptoms that would be present in anaphylaxis are going to be things like hives, widespread hives. The thing that we get concerned about is swelling in the mouth, in the throat, and in the airway. And the way that you're going to know that this is happening is that the kids are going to start having difficulty to breathe. Their lips are going to get swollen. They may be drooling more. They may not be able to speak, or maybe talking in shorter sentences. Their heart rate increases, and they get that feeling like something bad is happening. And it's mainly because there's swelling that's happening on the inside. A second phase, or we call it the biphasic, the second phase of anaphylaxis, are symptoms of abdominal cramping, vomiting, diarrhea. Kids can have lightheadedness, they can lose consciousness. So it is a very emergent and serious thing that can happen. And as I mentioned, anaphylaxis, even if the first phase, so let's say a kid has an allergy to peanuts, and it says for mild symptoms, give Benadryl. Benadryl is an antihistamine. It will help to block some of the response, but it is not a medication that, oh, I've given the kid Benadryl, they're fine, let me just not watch this kid again. That's not the case. If a child is going to have anaphylaxis, they need epinephrine, and that is period. End of story. Benadryl is not going to be helpful for them. So it is important to make sure that you are ready for to give that epinephrine. Next slide, please. So as I was talking about, once anaphylaxis start, epinephrine is the treatment. The only, I guess, bad thing about epinephrine is it's very short acting, so it's only good for about 15, maybe 20 minutes or so. And that's the reason why they always you need to call 911, because they may need more doses, or they may need like a continuous drip. It is not necessary to remove the student's clothing. You can give epinephrine through the clothes. There are different ways now. Our pharmacy still only has the EpiPens, but there are different things that I've seen, like it's like a little credit card type of thing. I forgot the brand name of that one. But basically, there's different ways of how to give epinephrine.
Nuvi, I think it's called.
Yeah, I can't remember the name. I just know that we have the EpiPens here. So the EpiPens, you will give directly on the lateral thigh, so the outside of the thigh. The main things that I want you guys to remember is that there are trainer pens. So if you do need some training, physical training, there are trainer pens also that come with the EpiPen kit. But you'd want to take off the blue cap, and then you want to firmly place it into the lateral thigh, so the outside of the thigh. And you will hear the click, and you need to hold it in place for at least 10 seconds. Do not use the, like in the movies, they talk about the EpiPens, and people have it like their thumb is like this. Don't ever do that. Hold the EpiPen like a pen, and then put it into the lateral thigh. And the main reason is because sometimes in the heat of the moment, everybody is kind of panicking. If you have the pen facing the wrong way, then the needle may go into your thumb rather than into your patient as you're giving them the pen. So don't hold it like this, like the movies. Hold it like a pen, and then insert it into their lateral thigh. Once you have held it in place for 10 seconds, then you can remove it, because that's the time that the medication will go from the canister into the needle into the patient. You should remove it, and then you should dispose that into a sharps container because of the needle, obviously. All right, next step. And then I'll go again, like I mentioned, you do want to make sure that you have called 911, as well as notified the parents that you've given EpiPen. Glucagon is a medication that's used for our diabetic patients when they have severe hypoglycemia or low blood sugar. And usually this is this is usually given if the patient is unable to take anything by mouth or they've passed out. Then you would give them the glucagon. You should also always call 911 if you are using this medication. The glucagon has very specific directions on it, just like the ones that you're seeing on this slide here. It's listed on the actual container for the glucagon. So just follow those directions on how to swirl the medication, how to mix it up, how to then give it. There are also different formulations of this. So when when the kiddo has glucagon, I think that everybody should get familiar with looking at that particular patient's glucagon so you can see it for yourself before you actually ever need to give it to that patient. The first thing would be if your kiddo is having low glucose symptoms, and it'll be listed on their diabetic plan that comes from the endocrinologist. It'll be listed as far as like, these are the mild symptoms and do this first. These are the more severe symptoms. The first thing really is a short acting or a very fast form of glucose in their mouth, right underneath the tongue. It gets absorbed very fast. But if the kiddo is passed out because of their low sugar, then putting anything in their mouth increases their risk of choking. And so that's why we don't want to do that if they've already lost consciousness. And so that's why you would give this glucagon. The next couple of slides just go over how to actually give the glucagon. The other reason why in step 7, how it says to have them be on their side, the main reason for that is because as this glucagon is kicking in and they're getting more and more sugar into their bloodstream, they may feel nauseous and vomit. And so that's why being on your side helps you to vomit out rather than inhale or aspirate or choke on any of your vomit. And that's the same safe position even if a child is having a seizure and you have to give them the diastat, same type of thing. You want to have them laying on their side so that if they're going to vomit, even whether it's food or their own saliva or anything like that, they could be laying on the side and it'll come out rather than them inhaling it and then having lung or respiratory issues. All right, next slide, please. So now this is the Form 1055 slide. And as I have said for the last couple of years, you guys are the experts on this form. This is not my form. So physically seeing the form, if you are new to the CDC or the Youth Center, is going to be the key so that you know exactly how the form is supposed to be filled out. Make sure that every block is appropriately filled out by the parent or by you as one of the CYP personnel. This is a legal document, so make sure that you are writing legibly and then, of course, writing in the appropriate black or blue ink. If there are any errors that happen, just like every other medical legal document, it's one line and then you initial, you make your corrections and you initial. Do not use whiteout or any other type of correction. Don't do squiggles, don't do anything like that. And the main reason is because this is a legal document, even if we know that we make mistakes, but we want to make sure that we're making one line through so that we can actually see what was written and then we can make the correction and see what was supposed to be written. So that is very important as far as just from the medical legal standpoint. The other part that is very important, and I know that all the CYP supervisors and trainers used to foot stomp this at all the other trainings that we've done, is that this needs to be verified every day. So every day, the parent or the legal guardian who's dropping off the child does need to initial that, yes, I still want my child to get this antibiotic or this ointment, whatever the duration of that medicine is. It's needed to be filled out annually for emergency medications, but any of the other ones, it needs to be annotated on a daily basis. And then the other part is going to be that you will document the medication right away, that when you've given the medication, you're going to document it on the 1055. And if the medicine wasn't given for whatever reason, so the kid was kicking, screaming, didn't take the medicine, or was kept spitting it out, whatever why the medicine wasn't given, that also needs to be documented in a timely manner. Making sure that the stop dates are filled out appropriately. And then like if it says for 10 days or 2 weeks that there's a start and stop date. This form is fairly busy when I've looked at it, so just make sure that you are familiar with all the different checkboxes and what needs to be filled out. And that is it on that one. And I know this is a small thing, so that's why it would be easier to just if you're first coming on board, look at all the documentation, take a little extra time to look at the Air Force Form 1055 or whatever new version comes out. Just make sure that you have taken the time to look at that before you even have to give any medication. And definitely, if it's been a while since you haven't given a medication and then you have to give a medicine, just be familiar. All right. I'm ready for concussions. Yep. All right. So concussions, what they are and how we can help our kiddos. Basically, a concussion is listed under the mild traumatic brain injury category. And you can get concussions by a lot of different mechanisms. You can have a fall, you can be directly hit. You may or may not lose consciousness. That's what LOC is for. Some of the symptoms, I really like the Delaware Return to Play guidelines because it very specifically lists out the different categories. So in the physical category, the symptoms that may happen would be headache, dizziness, vomiting. In the thinking or cognitive category, it'll be difficulty concentrating, feeling mentally foggy. Emotional, they may be more irritable, they may be feeling more, we call it emotional lability. Sometimes kids are just that way anyways, but they can be, emotional lability just means that, they're really either annoyed easily, crying really fast, or like really happy all of a sudden. Just that roller coaster of emotions is what emotional lability is. And then the other part would be the sleeps category. So either feeling drowsy, either sleeping more or sleeping less. These are all the different manifestations of how a concussion can present itself. The other emotional part really is that also just that feeling sad and nervous that can also be a result after a concussion. The schools here really do want us to be aware of all these four categories so that we can then look at how we can progress the kids out of their restrictions and returning them back to whether it's school all the way or their sports. The diagnosis is based on the history and the physical exam. Imaging like CT is not always needed, and it really is just dependent on what is happening, what mechanism of injury the child had. So just because a child fell and doesn't mean that they always need a head CT. So if you go to the ER, it's not that they didn't do their job or anything like that. It all depends on different criteria. But you can diagnose a concussion based on the history and the physical exam findings that we're seeing. The treatment is going to vary significantly depending on the child and the level of injury and what other abnormal findings were there. But the main therapy is rest, both physical and cognitive. And the cognitive rest really is going to be more towards the school part, but even at the youth center, I can see this being applied. The cognitive rest may be that this kid can't be on the computer playing video games because that is basically like a workout for your brain. And so we're trying to give them that cognitive rest as well. What I tell kids and parents is that about for a week after a concussion, it needs to be a super boring time. So no TV, no video games, no playing hard, no being on the jungle gym. And the main reason for that is because we want them to recover as quickly as possible and go back to all their normal activities as quickly as possible. Next slide, please. This is just a snapshot, an example of a return to play. But the main thing is each of the different states have different guidelines, and definitely there are more strict guidelines for our high school kids or the older kids that are doing more of the contact sports like football and hockey and those kind of things. But there are different types of return to play progressions. And basically, this is a graduated return to play guideline. And the main thing is, again, it needs to be that physical rest. And I totally get that it's very hard to keep a toddler from going back to the jungle gym. But at least for the first 24 or 48 hours for that, especially that small of an age group, at least if we can get them to not be on the jungle gym and not be climbing things for at least the first 24 hours, it's important. The main reason why these return to play guidelines were created is because it was designed to help the parents and coaches and teachers know how quickly their students and their kiddos can progress during the activity level. Each phase requires that a child has to be without symptoms for 1 week before they can go to the next phase. So all the different graduated levels of like, okay, they can do this sport for this amount. It all requires that they need to be symptom free for a week while they're doing that phase one before they can get into phase two. And the same type of thing happens even for the cognitive rest. Go ahead and next slide, please. So cognitive rest, like as I was mentioning before, is just as important as physical rest. So things that can make activities worse as far as our headaches and our symptoms worse after we've had a severe concussion are things like reading, video games, any kind of screen time. Those things make our physical and maybe even other emotional and stuff like that symptoms worse. They usually require 1 to 2 days off from school after they've had a concussion, and they may require more time depending on how severe their concussion was, as well as how they are resting or not getting the rest and how quickly they're healing. They may require additional time for tasks, maybe more increased rest time, decreased homework load, maybe postponing standardized testing. So all of those things are really dependent, and it's very important for the parent to have a conversation with the school nurse or with the school officials and let them know that, hey, my child is still having these symptoms. And so it is important to have that two-way conversation between the healthcare provider as well as the school as the children are healing from their concussions. Usually they can return back to full-time school when they can tolerate their activities for 30 to 45 minutes without having an exacerbation of their symptoms. And this is really well delineated here in the Delaware system as far as for their concussions. And I know that for all the kids that are doing more competitive sports, it's on the back of the school, the sports physical forms that we're filling out after you come in for your sports physical. It's one of those papers in the back also that goes over the concussion information for parents. Next slide. I know this is not going to be a great one to look at, but mainly this is just an example of the different types of school adjustments that they can do. The stuff really is maybe giving them an extra 20 minutes to do their reading. Maybe instead of 100% of their homework, they will only get 50% of their homework for the first week. And then as their kid is getting better, then they can slowly go up to like 75% of their homework. The main things for this really is to make sure that as a child is there in school, if the class is 30 minutes long, but 15 minutes into it, they're starting to get a headache, they're not able to focus, they're starting to feel dizzy. Those are things that they need to tell their teachers and their nurse that they're are having these symptoms, and then the cognitive rest or the school rest form gets adjusted. So it's on the back of all their cognitive rest, on the back of the concussion form, where it has the physical rest as well as the cognitive restrictions on the back, at least for the Delaware schools. All right, next slide. So concussion treatments, Tylenol, Motrin are okay, but we don't want them to be used more than just for a few days because you can get rebound headaches if you're continuously taking Tylenol or Motrin. Zofran is a medication that's used for severe nausea. And so if a patient has been having a hard time, then sometimes we do prescribe Zofran for a couple days. Melatonin is there for the sleep disturbances. Now, really, this would be if the kid is having their sleep issues progressing into that 3-4 weeks after their concussion, that would be a reason that they might need melatonin. The goal is to prevent a second head injury, and that's the reason why we are so concerned about the physical rest. So it's called second impact syndrome. And the main thing that can happen with this syndrome is that if you have had a significant head injury and you go back to your sport or you go back to whatever physical activity and you have another head injury, it may not have to be as severe as the first one. Your brain is still a little bit swollen, it's still a little bit bruised. And if you have a second head injury, then you can have worsening of that swelling and at a lot faster rate. And so that is the reason why there is all of these concussion rules and all of this return to play really stemmed from the fact that many athletes were being returned, especially in the football sport, but they were being returned back to play much faster, and then they were having more significant brain swelling with their secondary injuries, and that would lead to more devastating and potentially long-term problems for their brain injury. And it's mainly for that because of that rapid swelling. So obviously our goal is to prevent that second impact. If there are symptoms that are persisting for more than 4 weeks, that usually requires a multidisciplinary team. And that team includes sports medicine doctors, physical therapists, neuropsychologists. There is a concussion clinic up at Nemours that does take care of our patients who are having symptoms for more than 4 weeks, or if they've had a significant head injury. And so we may refer them sooner if the injury was significant. Prevention, we obviously know that we can't wrap kids in bubbles, bubble wrap, and they are going to fall, but definitely wearing a helmet for activities that require things like biking, skateboarding. It is important that they wear a helmet. And I always talk to my older kids. I realize, I get it, that it's not cool or it's not stylish to wear a helmet, but I always tell them that it's also not cool to have a head injury and not be able to do the fun things that you want to do because now you have this head injury. So that's probably the biggest prevention thing that we can do as adults, is to really help our kids know and take as many preventative measures as we possibly can to keep them safe. And next slide, and that's our summary stuff. So again, medications, making sure that we're giving the medication to the right person, the right medicine, the right dose, and the right way. Knowing how to use the emergency medications, when you would need to use them and how to use them, and then the documentation. And that is it for me. I am ready for questions.
Does anybody have any questions for Dr. Reyes? You can unmute your mic and ask her, or you may type it into the chat box.
Was there any questions already in the chat box?
We answered them.
Okay, thank you.
All right, if there's no questions, I want to tell you guys, I really, really appreciate the work that you do. I know I work with kids, but there is no way that I could do your job. So thank you so much for taking care of our kids. I know, I'm sure that there are days that are super challenging, and especially right now with all the stuff that's happening all around the world. I just want to take the time to tell you guys that I truly appreciate everything that each of you are doing for our children. Take care of yourselves, stay healthy, and let me know if you have any other stuff.
Dr. Reyes, we also want to thank you. You are always there for us. I mean, you are just amazing. Everybody in this group loves you. We hope you never leave us.
Well, I am leaving this summer, so.
Oh, no.